가 있습니다. 그래서 원래 16번째 맞는 애이고 원래는 뉴로 oncology와 스파이널 서저리에 대한 토픽을 가지고 국내에 아주 저명하신 연자분들을 모셨습니다. 그래서 우선 저희 교실 주임 교수님이신 김동규 교수님께서 말씀이 있으시겠습니다.
여러분 안녕하십니까? 이렇게 많이 모여주셔서 대단히 감사합니다. 지금 말씀드린 대로 올해 이제 16번째를 맞이했는데 뭐 갈수록 하여튼 더 순위도 높아지고 또 참여도도 높아지고 해서 아주 고무적이고 또 저도 기분이 참 좋습니다. 하여튼 여러분 다시 한번 이렇게 모여주신 환영의 말씀을 드리고요. 그다음에 오늘 이 오전에는 브레인 튜머 또 오후에는 스파인에 대해서 이렇게 공부를 할 텐데 뭐 프로그램에 있지만 하여튼 연자분들이 아주 훌륭하신 분들을 이렇게 모셨습니다. 그래서 많이 공부를 하시고 또 일방적으로 이렇게 듣는 것보다는 들으신 다음에 질문 토론을 활발히 해가지고 서로 의견을 교환하는 그런 자리가 됐으면 좋겠습니다. 다시 한번 여러분 감사드리고 오늘 많은 성과 있으시기를 기원을 드립니다. 고맙습니다.
첫 번째 세션의 좌장은 정의원 교수님께서 맡아주시겠습니다.
안녕하십니까. 첫 번째 세션 좌장을 맡게 된 서울대병원 정희원입니다. 소개를 영어로 드리도록 하겠습니다. 슬라이드 주시겠어요? Morning. I'm especially honored and privileged to have our special lecture on this neurosurgery update symposium, Mark Rosenblum. He's currently chairman of Department of Neurosurgery, Henry Ford Hospital, Detroit, Michigan. And he's also co-director of Neuroscience Institute and Hamelin Brain Tumor Center of Henry Ford Health System in Detroit. He's also serving as co-director of Neuroscience Institute in Royal Oak, in Michigan. Next, please. He received his MD in New York Medical College in 1969, and then he finished his internship in University of Michigan in Ann Arbor in 1970, and then he started his research training at the National Institute of Health in Baltimore for 3 years, and afterwards he joined University of California at San Francisco as a resident from 1973 to 79. Next, please. And he, after his residency, he joined UCSF Department of Neurological Surgery as an assistant professor in 1979 and associate professor in 1983. And then he became full professor of department in 1988. Next, please. 1988, in February, I joined his lab at the Brain Tumor Research Center. And for 2 years, I worked with him, and I really studied and learned a lot from him and BTLC regarding, especially regarding biology and tumor invasion at the lab. Next, please. Yeah, this is stereotactic biopsy for sinus infection patients. Next. And in 1984, actually 83, he founded the tumor joint section of NS and CNS, and he became president in 1984 and served as a president for 장기 집권했어요 for 6 years. 해가지고 he got a very honorable award 2004 Charles Wilson Joint Section on Tumor Awards at AANS in 2004. Next. In 1992, he moved to Henry Ford Hospital as chairman of Department of Neurosurgery and also director of residence training program in Henry Ford's health system. Next. It was taken in 1991 with my poster, worked with him, and 10 years later, more gray hairs, and yes, time flies, but 10 years, big change. Next, please. His major interest is neuro-oncology, and especially biology and therapeutics of brain tumors, and as well as CNS infection, including AIDS problems. His care philosophy is the very impressive one, and first, the quality of care for neurosurgical disease is possible in a caring fashion. And the second is the development of new knowledge and technology will improve the treatment of such disease. Next, please. He's not only an excellent doctor and a researcher, but also is very good father and good friends. So he has a beautiful wife and lovely one, daughter, Amy and Scott, and myself. Thank you very much. Okay, Mark, could you go with first? We're gonna have two subjects this morning, and he will continue from the first one to next one, and after his second lecture, we'll have a discussion, question and discussion. Mark, please.
Dr. Jung, thank you so much, and it's really been a pleasure to be with you and your wonderful faculty, and to learn more about the culture here. I'd really like to start off by saying 안녕하세요. Thank you. And I admire both what you've done here as well as the wonderful things happening in the country and in the culture that I've been fortunate enough to learn more about. What I would like to do today is to share with you recent thoughts on the role of surgery in the management of brain tumors and a couple of particular problems that we have to deal with in dealing with patients with tumors of the brain, and I'm specifically having to do with tumors in the glial series, so the invasive primary tumors, not metastatic tumors. In order to get through this talk in an appropriate time and leave some time for questions, I've put the two talks essentially together and we'll be going through some slides quickly and eliminating some, but in your brochure, in your handout, all of the slides are actually represented. So I will try to speak slowly and hit the highlights. The first thing to remember is that the field of modern surgical neuro-oncology is about 120 years old. 120 years ago, at the Hospital for Epilepsy and Paralysis in Regent's Park, and this is the picture, Regent's Park in England, Mr. Rickman Godley removed a tumor that turned out to be an oligodendroglioma. From then until now, there have been significant major advances in the management and the surgical management of this disease. We all know that we remove tumors for several reasons, for practical reasons and for theoretical reasons. The practical reasons, of course, are to obtain a diagnosis, to improve symptoms when there is mass effect and the symptoms are being caused by compression, to subsequently delay new symptoms as well, and increase survival from the surgery alone at least long enough for the patient to receive other therapies, which include radiation therapy most of the time, and sometimes chemotherapy, that have the greatest chance of, after surgery, of allowing the patient to live a longer life. Theoretically, surgery also removes poorly oxygenated tumor cells that are, we know, at least biologically, are resistant to radiation treatment, polyvascularized regions that are sequestered away from anything we give by vein, and to remove tumor cells that are either resistant to therapy or that might change from a lower grade tumor to a higher grade tumor. So we believe that surgery is important for those reasons. But we cannot forget that it's important, obviously, to obtain a proper diagnosis. And the only way, even in the modern era of modern imaging studies and other types of studies that we have to determine what is growing in the brain, but the only way to be sure is surgery. I'll show you an example here of this scan showing this clear-cut left frontal enhancing irregular tumor that absolutely is a glioblastoma that, when I took it out completely, turned out to be a metastatic brain tumor. Hard to imagine when you just look at that imaging study. MR spectroscopy, PET scans, and everything else that we would have said that was a primary brain tumor. And in fact, depending upon the patient's age, perhaps no treatment should be administered. That patient was alive and well 2 years later following radiation therapy. So we can't be sure. Furthermore, there are certain types of tumors frequently seen in the younger individuals that can be cured surgically by radical removal, as we know, including the ganglioglioma, the juvenile pilocytic astrocytoma, and of course the cystic cerebellar astrocytomas. The reason that these are surgically curable is because they don't invade the normal surrounding brain parenchyma, something that we'll talk about shortly. But remember that non-enhancing lesions of the brain, which we normally would think of likely to be slow-growing, low-grade tumors, sometimes are not. Here is a right frontal lesion that on biopsy, and this is a non-enhancing lesion, on biopsy turned out to be an anaplastic astrocytoma, a grade 3. Retrospective study of a series of patients at UCSF and other places have shown that at least 25% of the time, non-enhancing lesions on MRI scan as well as CT scans can be a higher grade tumor that can only be diagnosed by biopsy and histological confirmation. Recall also that in the modern era, we have been fortunate to be able to realize that there is a subset of tumors, even of high-grade tumors, the anaplastic oligodendroglioma, that if they show molecular changes, such as what we call loss of heterozygosity on 1p and 19q, in fact may be very, very sensitive to chemotherapy. At first, it was suggested to the procarbazine, CC, and vincristine chemotherapy, and today we give a drug called temozolomide, but it is thought that this particular type of oligodendroglioma, if they have the genetic alterations that I mentioned, has an 80 to 95% chance of sensitivity, truly changing the treatment that we would administer to such a patient. You can only find that out if you do a biopsy and molecular studies. We also need to recall that low-grade gliomas, astrocytomas, oligodendrogliomas, or mixed, are not necessarily benign diseases, are they? They may grow slowly, they may present with seizures, but this is a slide demonstrating the standard fibrillary astrocytoma, average age and onset of all of these lower grade gliomas between 30 and 40. Do not, after complete surgical resection, the patients do not have an average long-term survival, as they normally would be, but they die relatively shortly, with only a 20% 10-year survival in the low-grade astrocytomas. So these are not low-grade tumors. They are, in fact, high-grade tumors waiting to happen. These subtypes, all types, have the potential for malignant conversion in a stepwise process that's based upon loss of certain genes and control genes along time, and no one is for sure knows when this will occur. Actually, there's an example of one here that I operated on actually at UCSF and eventually resulted in a publication in PNAS. But it was back actually almost in the 1970s that this was observed by Müller and Afra in Hungary, where they looked at tumors that had been removed and then recurred, and they reviewed 72 cases of low-grade astrocytomas at the time of recurrence. Now remember, this is before CT scans, so this is very, very early work, but showed that the great majority of these tumors that recurred in their non-controlled series recurred as anaplastic or glioblastomas. Same thing with oligodendrogliomas, no difference. So we've known for a long time that these low-grade tumors can change into higher-grade tumors. I'm going to skip these slides just showing the Henry Ford experience, but just simply to tell you that, in fact, there are a variety of predictors that one can have. If you look histologically, one that we found several years ago was that if there are a larger number of small blood vessels seen in otherwise completely benign gliomas, there could be a the different prognosis of 4 years versus 12 years if there are more small blood vessels seen in low-grade tumors that are not growing, suggesting that something happens in an early fashion to link the development of new blood vessels and the eventual transformation of tumors from low to high. Now, what are the advantages of early surgery? Obviously, we're neurosurgeons. Hopefully, we believe in surgery. But are there advantages of early surgery? As we said, the radiographic diagnosis of low-grade tumors can be unreliable, and therefore, if you find something that requires radiation or chemotherapy to the benefit of the patient, it's better to make the diagnosis early, obviously. In addition, neurologic deficits, once they occur in these infiltrating tumors, may not be reversible with further treatments. Unless the form of treatment for any tumor type is highly effective, such as for primary CNS lymphomas, which will shrink with steroids and almost anything you give them, but that's not the tumor that we normally deal with, unfortunately. The possibility of long-term control has a direct relationship to tumor volume, and I'll share some experience in the past with that. Finally, as I've suggested to you, the likelihood of malignant transformation from a lower grade tumor is a function of the number of tumor cells present and the amount of time that you observe these patients. The change of the genetics in a low grade tumor occurs spontaneously due to spontaneous mutations. And of course, if there are more cells there to mutate, there's a greater likelihood of a mutation into a faster growing tumor that recruits new blood vessels. Okay, what about the role for surgery in addition, after the diagnosis is made, to define recurrence? In fact, is it a recurrent problem? Or, in fact, are we dealing with a complication such as radiation necrosis that I'll talk to in the last part of my talk? Well, of course, we all know that we have MRI scans and PET scans, and you do very eloquent work here on using the PET scans of 2 different types. We also have, all of us have some experience in magnetic resonance spectroscopy, trying to talk about evaluate the biochemical signature of the tumors. Do they have normal cells? Do they have rapidly proliferating cells? Do they have lipid? Do they have degradation products suggestive of necrosis? This is all based upon the normal spectroscopic imaging studies, particularly with choline and creatinine. and lactate, suggesting hypoxic and acidic conditions. Now, I won't go over this in detail, except to mention to you again that when one has a high-grade glioma, like a glioblastoma, we very commonly see an increase in the peak of choline in comparison to creatinine, with or without some increase in the lipid concentrations. This is useful most of the time, but nothing is useful all of the time. There are limitations for each one of these studies, and I'll share with you later our experience in just simple MRI scanning. But the same thing pertains to the PET scanning and spectroscopy, spectroscopic imaging, and others, that the diagnosis is accurate, I believe, in probably 85% of the time, in almost no study 100% of the time, to define, are we really dealing with recurrence, or are we dealing with necrosis from our treatments? Remember also that when we see a change on imaging studies, an increasing size lesion with mass effect following treatment, sometimes these are transient and even result in neurological deficits. But transient meaning that they will go away, and they're the natural consequence of radiation effect, of chemotherapy effect from wafers, for example, because these local treatments will kill the tumor cells in the adjacent area and set up an inflammation while the brain tries to get rid of the killed cells that we purposely did. That inflammation will manifest itself in swelling and a repair process that will look all the world like a recurrent tumor. Similarly, as we'll talk, radiation necrosis is one end of the spectrum, the bad end, where our treatment effect can look like a recurrent tumor. Now, obviously, there are limitations of resection, and as physicians, we all focus on, and as surgeons, trying to do the best we can for the patient, but avoid damaging the patient. We do not do a great aid to our patients if, in fact, they come out of surgery devastated. Unfortunately, we are not perfect, and sometimes cannot result in a patient not being quite as well after surgery as before. But the advent of studies that will help us identify the location of the eloquent areas of the brain, I believe, has been a major advance in minimizing the risks associated with surgery, particularly in important areas of the brain. And we rely on them more and more. Advances in mapping brain function, that can be motor, mapping the sensory area, the speech area, and I'll show you our results in mapping the visual cortex. Obviously, in the awake circumstance, which we use more and more, one can clearly map the motor area by stimulating the motor cortex as well as the deep projections. We can map the sensory area and ask the patient, are they feeling something abnormal? And the most important use of awake craniotomies is to map language. And that requires a team approach with our epileptologists we use and with neuropsychologists, reading and speaking, and has allowed us to do a significant amount of surgery and retain speech, which is so important, but even more importantly, to back off from surgery when it's clear that we could hurt a person permanently by our surgical approaches. Of course, we can always map the motor system with the patient asleep, but we have to watch out about giving too much anesthesia, which will modify the ability to map the motor cortex. And even up to 25% of the time with a patient asleep, sometimes it's very difficult to map the motor cortex and remove lesions such as this. Now, preoperatively, one can also attempt to map important areas of the brain, brain function, somatosensory potential, the junction between the motor and sensory strips, obviously, and these are all correlated with the MRI images, which then, when we use neuronavigation, can be correlated with function. Functional MRI scan can be used to map the motor area, theoretically speech, and vision. theoretically at least. We do not have a lot of experience on this. But magnetoencephalography, that I know that you have here as well, has a great hope in measuring, monitoring the location of the strength areas and the sensation. And I'll show you the vision. We don't have a lot of success in identifying where speech, however, is, and I think for a long time forward, awake craniotomies and language mapping is really the only satisfactory way to be sure that you won't hurt a patient's speech. We've had several years of experience using the BTI system that we have. I believe we have it for about the last 7 years in measuring and using magnetoencephalography to direct our surgery. And this is an example of a cystic tumor in a patient who presented with this left occipital cystic tumor with complete homonymous hemianopsia. And in the past, we would say, well, that tumor produced complete loss, and let's just take the occipital lobe out and be done with it. Well, it turns out that we did magnetoencephalography and found that, in fact, the visual cortex was still viable, and it was pushed up by the cyst and non-functioning. So we approached this case. This was the first one we ever tried. We approached this case from underneath, drained the cyst, took it out from underneath, preserving the occipital lobe, and noticed the vision partially came back. Never would have thought that was possible. So we've tested that on 21 patients, recently published in the Journal of Neuro-Oncology, 17 successful studies. We had 15 patients of the 17 had preoperative visual symptoms. 16 cases with these lesions, the pathways were displaced, and the surgical approaches were modified in 3. So it's not going to be helpful in all cases, but at least I could say in 1, 2, or 3, so perhaps up to 10% of the time, one can change your approach, modify it, and actually have a chance of retaining vision as a consequence of the magnetoencephalography visual evoked responses. An example of how technology might, in selected cases, help us. Obviously, in addition, the extent of resection has been aided by neuronavigation techniques of a variety of types that have been available for the last 15 years, along with 3D imaging studies, ultrasound, and now potentially the advent of intraoperative MRI techniques so that we could take these tumors and completely resect them more commonly. Intraoperative MRI scan is an interesting tool that probably will be most useful in the gross total resection of the low-grade tumors rather than the high-grade tumors. But certainly if the amount resected is important, as I'll show you, I believe it is, might also be useful in the higher-grade tumors. Well, what about, is surgery really appropriate for high-grade tumors? Will it make a difference on how much tumor is still there? And my belief, and many of our beliefs, are that cytoreduction, less getting rid of a lot of cells, is an important prognostic factor in itself. And I point out to one very old study, which is the first one that seemed to show it. And this is a study that was done, believe it or not, through what's called the Brain Tumor Cooperative Group that started to accumulate patients in 1967 with the first treatment with what's called mithromycin. In 68 and 69, the first BCNU treatment. This is a multi-institutional study, and so on, so that in the 1980s, the person who put the study together looked at the amount of tumor remaining the size of the tumor before and after surgery, and to suggest whether or not less tumor being present would make a difference in survival. This is the percentage, percent surviving patients over time. This is the preoperative sizes. So the preoperative size, large or small, did not make a difference in survival. But after an operation, and also after radiation therapy subsequently, the smaller the amount of tumor left, the better the prognosis. The larger amount of tumor left, the worse the prognosis. And this is an old representation of the types of results like this one by a fellow by a surgeon by the name of Mike Salzman, who looked at glioblastomas alone over the course of time, gross total resection, subtotal, and biopsy. Very, very early types of studies that have continued to be presented in the literature as more concept, because there's never been a prospective study comparing the extent of resection with survival as an independent variable in a series of randomized matched patients, because as surgeons, we frequently are biased either to remove more or less, and the patients come to us with that in mind as well. Nevertheless, the retrospective studies having limitations, I and most of my colleagues in the United States and elsewhere believe that removing more is better as long as the neurologic function can be retained. And this is a modification of a study that was done in Netherlands, quantifying the improvement or the deterioration of patients following small resections or large resections. And you'll notice that with the large resections, patients more likely improved than deteriorated, and less resection, as we all know, has a chance of hurting the patients. That change occurred many years ago, and it's clear one has to remove the mass effect in order to help patients. So with the modern era of imaging, of mapping, of technology, it's more likely that we will help patients by removing more than removing less. And this is a more recent study from the Glioma Outcomes Project suggesting that with craniotomy versus biopsy in a large number of centers in the United States, we certainly didn't hurt any patients by craniotomy. It might in fact have helped them. Now, one would say, well, what percentage of the tumor does one have to resect that we see on imaging studies? As we know, a glioblastoma presents itself, or high-grade tumor, as a contrast-enhancing mass. This is a cartoon of a 4-centimeter mass here, with a surrounding 2-centimeter area of what normally would be called edema. We all know that deal with brain tumors commonly that this is not just edema, but those are infiltrating tumor cells. And this is a model suggesting, closely from past biopsy results, of solid tumor and invading in the enhancing area and invading cells at different sites. Obviously, as you go further away from the tumor, less cells are there. Well, what would happen if you completely resected? You got a 100% resection of the enhancing lesion. Well, what would happen here in this model was that you actually still had a significant percentage of cells that are still there. In fact, is about 7%, if you believe this hypothesis that correlates with clinical results, 7% of the total amount of cells are actually still there outside of the enhancing region. So remember, a gross total resection doesn't mean completely removing the tumor, right? So a recent study by Raymond Sawaya at the University of Texas MD Anderson looked at 416 patients with glioblastoma multiforme and tried to evaluate if there was a statistical advantage by removing a large amount of the enhancing material, okay? And the results are best seen here in 233 patients with glioblastoma, new patients. You'll notice this should say greater than 93% resection, greater than 95% resection of the enhancing areas correlated with imaging studies, that there is a significant increase in survival, not a lot, but with a large number of patients that they evaluated, nevertheless significant change if you remove at least 95% of the enhancing lesion, which means if you've removed 90% of the tumor cells. We call that 1 log of tumor cells remaining. So in order to make a difference in malignant glioma treatment, you should aim, if at all possible, removing at least 95% of the enhancing mass, and know that you still have 10% of the cells still there. So when I try to treat someone, particularly if the lesion does not have a large mass effect, I decide whether or not I'm going to operate if indeed I can remove 90 to 95% of the enhancing mass. Now, we already talked about the limits of resection having to do with neurologic function, but what about the other issue that's common, in fact, part of the brain tumor problem, and that is tumor invasion. We know that tumors will invade at a local site. This was a right frontal lesion, and even at a distant site in a subependymal area. They will, in this different right frontal lesion, this is a post-operative, post-chemotherapy scan, might also not only spread to the corpus callosum, but actually spread by CSF pathways. So, and we also know from the work from Peter Berger, from Duke originally, a great neuropathologist, that at the time of first diagnosis, tumor cells are already spread at a distant site. Like we see here, infiltrating tumor cells, less and less cells into normal brain parenchyma. So we know that malignant glioma is a local disease, and it's also a diffuse disease. So we asked the question in the laboratory, if we can determine the mechanism of invasion, can we develop anti-invasion treatments? And I will go through this very quickly, but answer the question right now, it doesn't work. Even though we know that the tumors will spread in vivo, meaning in man, in certain pathways, we've identified the way that they will go. We've identified that they go predominantly by white matter tracts and local tumor spread, and the biologists then say, what are the substrates and the mechanisms? We can then identify 5 different mechanisms for the tumor spread. So we said, okay, if those are the reasons that they spread, let's develop a way to block each of these. So we did that with protease inhibitors, with integrin-mediated adhesion inhibitors, and what's called second messenger inhibitors. The first study that was done used a drug called Miramostat from British Biotechnology, very, very effective in inhibiting the enzyme responsible for tumor invasion. The summary is it was tried in man and it didn't work. So we tried a different agent in Henry Ford, a drug called CAI, that's a very potent second messenger system or signal transduction inhibitor. This is what it looks like. It actually, in the laboratory, in the laboratory Petri dish studies, as well as other studies, showed that it inhibited invasion, decreasing number of invading cells, increasing dose. This is a spheroid model of normal brain, which is in green, that's a normal brain model, like right over here, and a tumor that's put next to it. This is the control, tumor invading normal brain. This is actually in the laboratory and almost exactly replicates the human situation. When CAI is given, it completely blocks the invasion, and it concentrates in the brain if you give it IV. Ideal situation. And it also showed some disease stabilization and some cancers elsewhere. So we're going to try this, and we're going to absolutely stop brain invasion. It was done in our brain tumor consortium, what's called NABIT, with Johns Hopkins and Mass General and several other sites. This is the survival curve, and the problem is it didn't work with everything that we could predict in the laboratory. Well, why didn't it work? It didn't work because in the clinic, this is a very complex environment. It's a heterogeneous tumor. And how do you get it there, and how do you sustain it? And the question is, will anti-invasive treatment improve patient survival? We obviously have to treat it early because invasion starts early. It may be that there are individual things need to give into a patient, but I believe a cocktail approach combining here Miramostat, which was that agent that failed by itself, and temozolomide, when tried together in a study that was done in the other U.S. Brain Tumor Consortium, appeared to show an improved survival when giving an ineffective agent that stops invasion and a chemotherapeutic agent. So we should probably use anti-invasive treatments with surgery and cytotoxic approaches to decrease the cell number and the growth. Surgery is also useful for in stereotactic means and direct open means, but let me just mention here radiosurgery, because I have a bias here, and that is, what is the role of radiosurgery in the management of malignant brain tumors? Well, I think we have to remember the biologic keys to that question. Is this a local disease only? No, it's a local and diffuse disease with margins that are not clear. And even if you can give radiosurgery to the entire enhancing tumor, remember, 5 to 7% of the cells are not being treated. Radiosurgery, I believe, by any Linac approach or gamma knife in this particular circumstance is likely equivalent, and we could consider radiosurgery as a surgical procedure, just as a surgical procedure, to augment surgical results in radiating the enhancing area, but remember that the tumor cells aren't only there to treat recurrence of certain in the diagnosis and making sure you're not dealing with radiation necrosis with the limitation of size and contour and with the addition of the potential for radiation necrosis leak. There are other ways that one can use stereotactic surgery for brachytherapy or single injections of viruses or convection-enhanced delivery, and I can answer a question later on that if you'd like, that might have some use. Or direct open intraparenchymal treatment of using several agents like radiation that can be given by a balloon system that was recently approved, or single agent delivery or the administration of Gliadel. This is the what's called Proxima balloon, the glia site that sometimes can be administered. This balloon is put in the bed of tumors, liquid radiation administered afterwards, removed, and therefore can very finely give brachytherapy to a local site. The problem is it works only slightly in recurrent gliomas. It's too toxic for primary tumors and probably is more effective in metastatic lesions. So in summary, you have to remember that the targets of brain tumor therapy depend upon where the tumor is. The local treatments, of course, are surgery and radiosurgery and polymers. The regional treatments include brachytherapy and conformal radiation therapy, intraarterial, infusional types of CED, and diffuse treatments that sometimes are necessary because these tumors will invade diffusely. And we have to remember all of these different treatments that are available to us to treat this type of a tumor. Now, I'm going to change here quickly and talk about the other aspect of the talk, and that is the significant problem of radiation necrosis. Because I think I know, in my opinion, and in many individuals' opinion, radiation necrosis is something that has not been observed, not been thought of often enough, and including myself, and it's a major issue that we have to address. I'm indebted to my colleague Lisa Rogers, one of our neuro-oncologists, for much of this work. Remember that radiation necrosis, when we deal with, that's damaged tissue, when we deal with malignant gliomas, is a problem of the part of the neoplastic process itself, and therefore its presence doesn't mean that we've caused the problem. But it also, as we mentioned, can be a consequence of therapies, and you should know that standard fractionated radiation therapy at over 5,000 rads of 50 gray has about a 5% chance, particularly if you're close to 60 gray, 5% chance of causing radiation necrosis, which we're clinically not very aware of. Depending upon the type of brachytherapy, up to 50%, and radiosurgery up to 10%, causing the necrosis. Necrosis can also occur with a combination of chemotherapy and radiation, if that chemotherapy is a radiation sensitizer, and also a consequence of effective local treatment, including intraarterial chemotherapy with streaming of drugs, so it's too high a concentration, and convection-enhanced delivery if, in fact, we're looking to kill the tumor. I will show you a couple of illustrative cases that speak of how common this is and how it's surprising. This is a 36-year-old man with uncinate seizures, partial complex seizures. In 1994, they presented with this lesion. So I did a gross total resection of that right temporal tumor. It was an anaplastic astrocytoma that was growing fairly quickly with a Ki-67 of MIB of 30%. So we gave standard just 55 gray of external beam radiation therapy and procarbazine, CCNU, and vincristine therapy for 1 year. 1 year afterwards, the patient was neurologically normal, and the scan looks like this. This was 11 years ago, huh? And 2 years after the operation, he started to develop weakness in the left arm. That lesion enhancing had a positive PET scan. I was absolutely certain that this was a recurrent tumor in 1996. So I removed it. It was necrosis, purely. 4.5 years later, this is what he looks like. He's alive and well 11 years later, and he fundraises for my department. He just got an award and raised $200,000 for brain tumor research. That was recurrent tumor, PET scan positive. Obviously it wasn't. Here's a 50-year-old with headaches presented with a solitary lesion on the left frontal lesion that on resection was a metastatic papillary adenocarcinoma. I gave only radiosurgery to that site at only 14 gray to the tumor bed. Later on, a lung primary diagnosis was identified, treated with chemotherapy and radiation therapy. And 1.5 years later, he developed 5 other enhancing lesions. The original site here is clean. So we got whole brain radiation therapy. Eventually, half a year later, I actually took out an occipital metastasis and gave radiosurgery to that site only, and then a routine follow-up. And 3.5 years after the diagnosis, he presents with this lesion that is in the left frontal area, the area that we gave a small amount of radiosurgery and the standard whole brain radiation therapy a couple of years later. Resected that completely, pure necrosis. He's alive and well 6 years after the brain metastasis. We're lucky here, obviously, but that lesion was not expected to occur. It was necrosis. Just one quick one, another 71-year-old patient who was sent to me after having had too much radiation, unfortunately, whole brain, because they thought it was a metastasis. Then they said, well, maybe it's not. Let's give some more. Presented with this lesion, operated, it's necrosis. I said, it can't be necrosis only. What's the lesion? So here it started to grow as a mass. So I said, okay, let's use neuronavigation and exactly take that tissue out. It was necrosis again. So we felt that this was most likely a malignant glioma with necrosis. We treated him for necrosis. The lesion got bigger, gave hyperbaric oxygen, the lesion shrunk. Unfortunately, eventually the patient did succumb to a glioblastoma. So the question is, how do you differentiate between this problem of tumor recurrence and radiation necrosis, as well as the temporary changes that occur when we're trying to affect local control? Imaging studies? Well, we've looked now at standard MRI scan in actually 44 patients. This will summarize 41 patients, 18 females, 23 males, average age of 48 years old, 34 with gliomas, 5 with metastases. This is what the average scan looks like. Classic appearance of what we call a Swiss cheese area of contrast enhancement with a feathery irregular margin. These are all operation-proven pure necrosis, either from the operation or subsequently the medical treatment of it. These tumors may invade in the subependymal area. Look at this. Subependymal enhancement. This has always been thought to be glioma, okay, or tumor. It should not be anything other than that. Wrong. Here's a lesion that's crossing the corpus callosum, enhancing it. This is tumor. Wrong. This is radiation necrosis. When we looked at the 41 patients described here, half of our patients, if the lesion, radiation necrosis, was close to the ventricle, demonstrated enhancement in the subependymal area. And a quarter of them, actually, when they're close to the corpus callosum, show corpus callosal enhancement. So we don't have a clue on the imaging studies whether or not these lesions are necrosis or not. The only exception, and it is an absolute exception, is if an area of enhancement occurs across the midline and across a dural multiple peel interface. That has to be necrosis, because obviously, as long as there's no enhancement going through the corpus callosum, and that has been found in 4 of our cases. So can MRI scan be useful? No. Can PET scan be useful? Maybe with methionine. We don't have that available, but again, I don't think it's going to be 100%. Can spectroscopic imaging be useful? Possibly, in comparison again to the normal. Here's a study showing, looking for necrosis versus glioblastoma. That looks like glioblastoma. Spectroscopic imaging suggested pure necrosis. So my partner, Dr. Jack Rock, who runs the surgical program with me, looked at a variety of different 27 patients, 99 spectroscopic evaluations, looked at the correlation between the ratios between all of these chemical signals, and the summary is that it doesn't work perfectly. There are hints using spectroscopic imaging that one is dealing with pure tumor or pure necrosis, but nothing is perfect. So really, in this type of tumor, MRS is not perfectly valuable. Perhaps a combination of imaging studies would be, it's more likely to be valuable with metastases because it's rare that there is a combination of necrosis and tumor with metastases. And advances hopefully will help us better later. But when in doubt, biopsy. Now, does it make a difference if you have no treatment available? Maybe it doesn't make a difference, but I believe that there are some treatments that are available. Furthermore, if you know that there's necrosis, would you ever give more radiation? Well, if you don't know about it, I know I have treated radiation necrosis with more radiation. That doesn't sound very good. It's not very good for the patient. That was when we were much more naive in not knowing what we had. So we want to avoid that. Remember that surgical resection, gross total resection of pure radiation necrosis is a very, very effective treatment. And medical therapy, if there is residual disease that is seen that looks like pure necrosis, or if you completely resect a necrotic area that has recurred despite prior complete resection, should be treated medically. And I'll just show you a couple of cases here. Here's radiation necrosis. Here it has nearly disappeared following medical treatment. Here's another case, biopsied in this case. There's one section that went away with Trental vitamin E and anticoagulation. And so we use now, although we haven't done a complete study yet, a retrospective one is in press right now, steroids, anticoagulation, vitamin E, what's called Trental or pentoxifylline, and occasionally hyperbaric oxygen to treat necrosis. Steroids reduce edema and reduce inflammation. Anticoagulation, in addition, inhibits neutrophils getting to the site and prevents the release of serotonin. Trental increases red blood cell deformability to get more oxygenation to this area. Vitamin E scavenges free radicals. That is probably an important part of the necrosis process. And hyperbaric oxygen, in some places believe very strongly on, and in certain circumstances clearly can help in the management of radiation necrosis. Our very brief experience suggested only in a number of patients that we've treated that we have seen about 1/3 of the patients have a lesion go away with medical treatment when appropriate, but never any lesions go away without attempting this, either surgery or medical treatment. So we proposed, as in your handout, a series of medical treatments which haven't been proven yet. But remember, surgery can be curative and needs to be administered when you're sure that there is radiation necrosis, as long as you don't hurt the patients at using the modern techniques of mapping and the modern surgical adjuncts. In conclusion, as you see here, there are a large number of people. One can never do anything alone. This is our group in the clinical aspect of the Hermelin Brain Tumor Center. Dr. Mickelson, who runs it with me, Dr. Rocker runs a surgical program, 2 other surgeons, our neuro-oncology nurses. Nursing is very critical to treat this disease. Our medical oncologists, neuropathologists, radiation therapists, and so on, and a number of different laboratories, mostly working in molecular treatments, invasion, anti-angiogenesis, model systems, nanoparticles, viral therapies, and adjacent other laboratories that contribute to the what we call the Hermelin Brain Tumor Center at Henry Ford. Thank you.
Thank you, Mark. Was really a very comprehensive and informative lecture. Thank you again for your effort. We'll have a few questions or short comments. Dr. Ko.
Thank you. This is Dr. Go from Konkuk University. You presented very concise overview of malignant glioma treatments, and you showed us the the amount of resection correlates with the prognosis of this tumor surgery, and also you presented some functional preservation surgeries and advantage of MEG case in occipital malignant glioma case. So sometimes it is contradicts between this function preserving surgery and the radical surgery for tumor. So what is the strategy of choosing this radical surgery against this functional preservation surgery? And another question is, what is the treatment strategy of gliomatosis cerebri?
Gliomatosis cerebri?
Yeah.
I'll answer the last question. Gliomatosis cerebri is more commonly a lower grade tumor that's spread all over the brain, and sometimes an anaplastic tumor spread all over the brain. Prayer. That's the treatment for gliomatosis cerebri. It is impossible to treat. Unfortunately, if one is, most of the time we do a biopsy to confirm this. One would have to give whole brain radiation therapy, which we would probably administer, and temozolomide during the radiation and afterwards for a year. But patients like this, if they are certainly changed into a higher grade tumor, don't live a year. So it's very, very difficult. They'll frequently be disabled by the brainstem and other invasive lesions. So that's a tough one. That's a real tough one. Interestingly enough, gliomatosis cerebri is a tumor that has the greatest invasive ability with less growth ability. So remember, that actually confirms that there's two processes that our scientists hopefully will help us better understand. Okay, so we don't have any treatment for that. I believe in radical resection when it can be done safely. That's the key. In non-eloquent areas, radical resection, and I would say the non-eloquent areas, probably 90-95% of the time, there is no abnormality seen on the enhanced scan after we operate. But they all come back. When it's in an eloquent area, and in brain tumor centers, we usually get sent those that are on the dominant hemisphere. The left temporal brain tumors are the most common tumor I see. It's amazing. But no one wants to touch it because you'll hurt the patient. And our attempt at removing these tumors as much as possible completely depends if we don't hurt the patient. And I will try to remove it, as I said, if I can feel I could remove 90 to 95% of the lesion. If not, if there's mass effect, I'll still try to get rid of the mass effect, because that's a real indication for surgery. But the debulking to take all the remainder, I will temper with the imaging studies and the mapping studies as long as I don't hurt the patient in the glioma. Remember, sometimes you're surprised. Sometimes you find a lymphoma. Sometimes you find an abscess. And when we have an abscess, we sing and we cheer, and so we're not as good as we think we are. So we do believe surgery is necessary. And we try to be respected if it's not going to hurt the patient.
Okay, more question? Dr. Park?
Thank you for your great lecture. My question is that, do you think there is a clear-cut separation of diagnosis between radiation necrosis and tumor recurrence? Because many atypical tumor cells were found in the pathologic specimens such as radiation necrosis. It's obviously atypical tumors, but it's a real tumor cells maybe.
Yes.
So it's a frequent situation we can met. So what's your interpretation of that?
Well, first of all, I think in every patient with a malignant glioma, there's a tumor cell. Okay? So the question is, are these tumor cells growing? Are they not growing? In the area of necrosis, yes, we see pure necrosis, and we see some scattered cells that we hope are non-viable. Our practical experience is that that is, for practical terms, not tumor. Well, we resect it all, not viable tumor. Okay, we know that if we don't do anything, the tumor will come back. So we are addressing the issue of necrosis versus tumor for two practical reasons. First of all, to try to stop something from growing that will hurt a patient and it's not tumor, and that's either with surgery or medical treatment. And the second thing is, as importantly, to avoid giving more radiation to someone who has radiation necrosis already. And that's frequently when you have nothing to do and these lesions are growing and it's failed chemotherapy, well, maybe we do nothing, maybe we'll give some more radiation. Okay, it's an enhancing area, let's give some more radiation. Well, if we knew that was radiation necrosis, we wouldn't do that. So we're trying to handle a very practical issue of growing lesion, but understanding that there's always tumor there, and rarely, like I showed you that 11-year survival, rarely and occasionally you will have successfully kept the tumor down and have someone who lives a very long time as a consequence of dealing with that. Because if you don't deal with it, the patient will die of the radiation necrosis.
Okay, Professor Joe. Could you use the microphone?
We know that in radiation necrosis, sometimes the mass is increasing, growing. What is growing? The tumor cell or the inflammatory cells, or what is the
What's growing in radiation necrosis? Well, histologically, it's vascular changes with thickening of blood vessels, like a little stroke. There are also a large number of macrophages cleaning up dead debris, and probably causing more. There are biochemical changes that actually are damaging themselves, and sometimes a continuously expanding process. So it's not tumor. It's free radicals. It's vascular ischemic events that somehow do not stay localized, but continue to cause more damage as one gets a distant site. So it's not tumor, and therefore it was surprising to me that the vitamin E threshold anticoagulation, hyperbaric oxygen, works sometimes, and it does. That has no anti-neoplastic effect whatsoever. So it's a good question, because if you knew exactly what you might be able to develop a new and novel, maybe molecular biology approach. And unfortunately, the people who have studied this the most in the United States have given up studying what the cause is. People at UCSF and others, because it's so complex. And so maybe we'll try, but I don't think we'll be any more successful.
Short question regarding radiation necrosis. How often reoperable for growing mass who underwent radiation? How often?
How often will the radiation necrosis be operable? Most of the time it will be if it's surface. Remember, if it's deep in the basal ganglia, and that's why we gave, say, additional radiation to this lesion. It's more difficult than we would rely on the medical therapy after biopsy proof. But I would say the radiation necrosis is probably surgically at least significantly removable in 80% of the time. It's of note, and I didn't mention that, but in the patients that we've had pure radiation necrosis, 44 patients, almost half of them had standard external beam radiation treatment. This is not only radiosurgery or brachytherapy. Half of them had 60 grade for glioma, or 30 gray over 2 weeks for metastatic tumor, something we thought was safe. Another quarter of them had pure radiosurgery or pure brachytherapy. And the other quarter had a combination of the two. This occurred in a mean of 14 months after the first radiation, but there's a long spectrum. So what I'm saying is that anyone who has received radiation therapy, you have to be aware that this is a possibility, and for sure, if we've given focal radiation therapy alone or after standard radiation therapy, always think about it. These days, we can biopsy things very safely. That's surgery too.
Okay. Could you summarize your perspectives in future treatment of malignant glioma, or with the greatest hope, either gene therapy using convection and stem cells?
First of all, let me tell you how frustrated I am. I've been working on malignant gliomas for 35, we could administer to individual patients that will be perhaps different from one patient to another. I think the issue is getting the molecular treatments to the tumor cell and all the tumor cells. So I believe administering agents, whether it be proteins or genes, by convection-enhanced delivery right into the brain, which will actually, if we can prove it, flow to the invading tumor cells, like the tumor cells move, or administering genes through viruses themselves that if we can get them to move, or stem cells that will home to certain areas and through bystander effects have an effect on more tumors, either by enhancing in the immune system or by actually stopping them from growing, is really the future. I do believe cytotoxic approaches will continue to be a part of it, and anti-angiogenesis agents, and I do believe that surgeons, if we continue to take the lead in the treatment of malignant gliomas, will always have a job.
Okay, thank you. Lastly, I'd like to make announcements and apologize for one misprint in his CV. Page number 3, pre-medical school, 1986. He graduated from pre-medical Seoul National University College.
I consider that an honor.
I'm so sorry, but
I consider that an honor, and I think I'm going to leave it on my curriculum vitae, if it's okay with your dean.
thank you. All right.
감사합니다.
감사합니다. 감사합니다.
그 감사장 전달. Letter of appreciation, Mark Rosenblum, Department of Neurosurgery College Director, Hamlin Brain Tumor Center, Hannaford Hospital. On behalf of the Seoul National University College of Medicine, I take great pleasure in presenting you this letter of appreciation in acknowledgement of your lecture, Modern Surgical Approaches and Limitations, the Problem of Brain Function and Tumor Spread, and the Problem of Radiation Necrosis, given to audiences of Neurosurgery Update 2006 at this college. March 18, 2006, Kyu-Chang Wang, Dean, Seoul National University College of Medicine. 사진은 이따 시간이 지금 저 10시 반까지 커피 브레이크가 있겠습니다.